know, people that may not, you know, when they need a low sodium diabetes should probably be taking care of that.
Because that's going to be one of the injects you're going to be given on February 16th, is dealing with food service and how we're going to feed these people over a period of 2 to 3 days. So,
Any more questions for setup and actual Shirley, who's in charge of the building and stuff? Good job? Everybody agree? Lots of good questions. We'll get a walkthrough, but now we want to give Carol, who's the incident commander, who's at the command center here, right? Give her a report, and then if you could just, what kind of groups did you identify, and then if they could just give a quick report.
Okay, well, first I guess the liaison. She's because she's going to be telling. I mean, she told us how many people were coming, and so we'll let her. Yeah.
Well, okay, I'm the liaison between this facility and EOC. Okay, so I'm going to be communicating with them by either amateur radio or Mark's radio or phone, if that's whatever means. There's all these different means of communication. So I relate the information to the planning chief.
Yeah.
That, you know, we have 30 patients and, you know, the basic information. And then I'm also the person that they're going to come to when they identify something that can't be taken care of here on site, where they're going to need something maybe that we're going to go over to the EOC and ask for resources. Okay? So that's what the liaison's for.
Good. What's another group that you identified?
The operations.
Operations. What's operations? What did Steve call those guys? They're the what? Doers, right. So what would you guys identify as operations minded?
We identified top 5 needs that we thought would need to be addressed immediately: staffing, meds, food, security, and then hands-on care. We knew that the patients were stable, they weren't critically ill, there wasn't any oxygen or any of that extensive care stuff coming. We talked about the medication cart app being able to just be rolled onto a transportation vehicle and brought out here. So that would give us emergency supply right then, right there, for whoever may be here, what meds they may need immediately. We talked about how many staff. We would look at, and we decided to look at it at a bare minimum aspect, that aides could provide probably care for the 30 people that are here. And then we talked about RNs that are available to kind of oversee them through the core. We talked about food. If we had use of the kitchen, we talked about just doing a general diabetic diet for everybody, maybe low sodium. We talked about security and the positions of security officers would be within, at the front door and the back door. And then we talked about the direct care. Some of the things we identified we needed to look into more was like medical equipment, looking for commodes or wheelchairs or walkers or crutches for some that may need them that didn't come with them because they didn't grab them or they forgot to bring them with them. We talked about the refills of medications. Would our on-site pharmacies be able to reroute instead of delivering to you just tell them where the address is and now they're delivering, because most of them are out of the county and in different towns. And then we talked about the different modes of communication we had available.
Everybody agree those are 5 great objectives in the first hour? Steve?
Yeah, they did a great job.
What's another
The
group?
one thing that we talked about that we have mentioned was the pets. We also talked to some of these people in assisted living who have pets, so when we interview, we call them. So we're going to utilize our local veterinarians.
There's probably families that would take the pet and not the parent.
Right.
How about those?
That would be my dad.
I know for the vet, but for the seeing eye dogs, the blind person, that seeing eye dog should stay with that person.
Sure, they would have to, so, I mean, that's their part of that.
Service dogs are a big thing right now too.
Oh, yeah.
What's another group? Hey, great job, first hour. And that's important. Why would we talk about things day 2 in the first hour? Everybody agree? Mark, anything?
No, that's good, positive thought.
What's another group that
The
you
logistics.
identified? Logistics.
Yeah.
So who's logistics? The
That's
what?
me. And actually, she just
getters,
everything
right.
that we did, we're the getters.
So what do you want to get in
So-
the first? Let's just keep it to the first hour.
Well, the first hour, what we thought we needed to know is what kind of patients we're getting. So we need to know what we need for them as far as for supplies and things like that.
I think we've identified that today. These are
Right, and then we needed to know what kind, if we, about the medications, we did that. We also talked about staffing. We'll need a variety of people, 2 nurses, 4 SNAs. We also need the twin cooks that could help with the food if we're able to use this site, you know, that kind of thing. We also talked about coordinating with all the other nursing homes in the county here, primarily right here in the city. If it's only 30 patients, we thought that we could utilize our kitchens and the other facilities to help, you know, a few more meals. Isn't going to, you know, be a hardship for anyone. Yeah, good strategy. And then also rotate. Either we could do it 2 different ways, whichever way would help. We could either have each facility donate, you know, 10 meals each of the 3 lunch right here, or one could do food one day, one could do transport to something else. So whatever works for the team. We thought for immediate need, we could, this is kind of, call Steve 1-800 to Steve and say, can you give us $30 lunches for the first meal while we
We'll be in Afghanistan. Where it's safe. Where it's safe.
We're safe. So many. And then we did talk about all the medications and stuff too, how much medications that they have. We needed to know if there's any new admissions in last 24 to 48 hours, because sometimes there's a delay in getting medicines from pharmacies, so we wanted to make sure we had could utilize our local pharmacies to get those immediate needs that we couldn't supply. Also, something that was important to us is we wanted to know if any of these patients were hospice patients, but if it's assisted living, I don't know if you take a hospice. Yeah, so we would like to know that because we want to get hospice involved, and you know, because they could maybe help us out or take some patients to the hospice house or whatever.
Hospice is in some memorandums of understanding already, just so you know, because they can't take.
Yeah, so we wanted to do that. And then also, we didn't put it on our list, but it's on my mind, is we probably would want to have some social service from any of the facilities to come in and help with our patients, because I really believe that even though they're stable, walking, talking, great people, as soon as they hit the floor here, then the anxiety's
I
going to
can
start
tell you,
coming in.
anxiety is going to rise. Everybody's going to be nervous.
They are.
What are elderly people creatures of what?
Habit.
Are they going to be very happy?
No.
Are they happy just doing fire drills?
No.
And beyond that,
Yes.
you need to also take into consideration what mental status and emotional status are the families
Right.
that have these patients here. You're
Right,
going to have to figure out how
exactly.
you're going to deal with them as far as talking to them social service-wise,
Right.
counseling, what have you,
Right.
assuring them that what's going on here is okay.
Yeah, I've got some of it. Yeah.
So one thing I've heard, especially out of Char's detailed brief there, is there's a lot, you know, and this is going from remember incident command mission. The mission is to establish an alternate care site to care for safely and provide for the care of 30 patients for a period of 96 hours. You know, that's the mission, right? Priorities are safety, feeding, security, okay, access, blah, blah, blah. The objectives are food, drugs, da-da-da, okay? Strategies are, we've heard some, hey, we could go to McDonald's, hey, we can feed here, hey, we could use strategies, right? Tactic, lowest level, last thing, tactic. A tactic for getting at all these questions about patients. Why not, is the thought, develop a checklist of all the things we need to know about a patient.
That's a good idea.
Diet, meds, family, pets, social services, hospice, da-da-da-da-da, a checklist. That would be a tactic. So I wanted to kind of bring that up as maybe a real live
How much
tactic.
would
But
that be?
Most of that information is already on the face sheet.
Yeah.
Minus the
so we
diet.
don't need to reinvent a wheel.
Right.
Okay? So but that's just, I went through that to kind of take you through the hierarchy, okay? Mission, priority, objective, strategy, tactic. You need to, that's how we need to think.
Right.
When we're thinking about all this, that's why it makes it hard, because I saw in our group, one observation was we went right to the tactics.
Well,
Okay, hang on a second. But that's normal. It's normal because we're all fixing people. We think in our minds what it is the solution is, and we go right to that without stepping back and looking at, okay, what was the objective? What are the different ways to accomplish it? Strategies. Talk about those strategies. Agree on a strategy. Maybe you have one or two. Put that in your plan. And then specifically how you're gonna accomplish that strategy. Okay, what are you gonna do to get that strategy done? And that's the operations section, right?
You know,
So
can
just,
you put a med sheet with the patient that comes and how long will that take with that when that's allowed?
Which opens up another thought I wanted to share with you. As we talked about it at our sub-meetings last week, but it's still like, that's why I brought my laptop today mainly, was because 3 out of the 4 local nursing homes are all on point-click care. 1 is not. So all of our patient information is right there. So IT would be supportive, it would be much easier so that we can, because we can tell you, I can look up the jobs I had. And so could Sarah and Carol.
But I'm gonna tell you,
Well,
AL is not
Velma's
electronic at all.
You're not at all? Yeah, so you would have to bring paper chart, but as long as we had our stuff, we could tell you everything, family contact, everything's right there. All their disease process, their mental status, all that stuff.
And Matrix
So-
can be pulled up the same way.
Matrix could be pulled up the
So
same way.
one of the
exactly.
things we need to discuss with the Career Center is
Exactly,
locally for access to
yeah.
whatever.
Yeah, because just like, and like today it brought up when I was, we can't, it has a guest Wi-Fi here, but we don't know the password, so you can't get on. So those are things we have to have in our plan, so we had it ready to go, so. Let me see what else. I think that was pretty much all we had, because what's your name? Heather had most everything on it that we talked about at our table.
But, and Steve mentioned, we're all fixers. We're fixing people. We all jump into the tactics. One thing, and everybody's done this, Mark's done a lot of these. Every single one of us has done the same thing. And that's why we do these. Get back up here, not here. You hear that in the weeds and 5,000 feet. And today we want to identify those things, but also try to do the walkthrough part. One of the things that's nice about Incident Command, remember, and I thought Carol did a good job of that, is you have limited people within that first hour. So what are those positions you want to put in first? And Carol did operations. What else? Logistics.
Safety.
In planning. Right? So all the things that, what do I have going on, what I need to do, and what do I need in the future to do. Right? So now we can expand that as people come on. So who else did we expand to? You said safety and planning. Are you planning, sir? You give a quick report on.
Safety and security, and we had one person do.
And is that a big deal right now because nobody's here, right? What do you have come up with in planning? Did you identify it? And remember, we have the worksheets here too.
Right, yes, and then we did talk about what were the big points, of course, to look at, but, they're just determining, basically,
Everything
the
we
plan
kind of-
expands as you go, because as more people come in, you're gonna realize, okay, you're the person that's ideal for this role, and you put them in that, but, I think we had our bases covered rather quickly, obviously, in our drill, but.
It's the nurse things.
Just a thought, it may be down here, but just thinking through, when you're talking about security, do we, and you're thinking about people coming in the door, we need to be thinking a little bit possibly?
Probably sure, right? Nurses?
Of course. You know, I think the challenge.
The paper's gonna be here. They're gonna be wanting to take pictures. You want your patients in the front page of the paper?
That's where you go, direct care.
Security, you have a good point. And again, probably after the first hour, several hours into the first day. And I know the plan to permanent care, or your building is back functional or semi-functional.
Right.
Is very fortunate. They have many, many buildings. If they lost one, they could put 100 people in 5 other ones.
I know. When our logistics chief was talking about bringing her social worker in, I know that your facilities have activities directors. When you're talking about social emotional issues that these people have, their creatures have it, they're gonna be more silly. Here, can we bring in an activities director to do some things with?
2 days later, day later, not the first hour. Right?
Right.
I think we want to do a walkthrough. Shirley, if you could lead.
Before we go, yep, you're gonna leave. Before we go, just put on this by Mark. I think it'd be important, if you really do, I've been talking about staying up here and going down and not going too far in the weeds. Now I'm gonna flip. What I heard was a lot of really specific, good ideas, and I think this group could probably arrive at solving, coming up with some real concrete, this is what we think we should do as a group about. So think about between now and say, after lunch, we'll do it in about a half an hour, we'll take about 30 minutes. Do we really want to try to drill down on this feeding issue? Do we want to drill down on what do we need to know about patients that come here? Do we want to drill down on, let's get a really clear, concise security plan? Do we want to drill down on how are we going to communicate to call out the teenies? Let's come up with one thing that we think today. So I think it'd be great if we could walk out of here with a solution to something, okay? And then everything else is kind of still at a strategy level. But what do we want to try to solve today with all these smart people in the room? Because this is a great opportunity for us to do that. So think about it. You don't have to answer
Gives
now.
us a chance to get into the weeds.
Think about we're going to get in the weeds. So think about, so we're all going to have to kind of agree on something, and we may say, I think this is more important. But we're going to come up with something, okay? And we're going to try to solve that today as close as we can, so we actually can all walk out of here and go, you know what? We really figured out how we're going to do this. The rest of it, we just got to figure it out. But so think about that.
I have a question. Ken, I don't know if you covered this before I got here in the room. All of you were spoiled from the standpoint of fire coverage, squad coverage, what have you. Because all of you, with the exception of serviced by Ashland Fire, for the most part. It was a full-time fire department, readily available to respond to whatever. Where we sit today is not in Ashland Fire Department's jurisdiction. Primary response agency is going to be where we sit today. We need to take that into account when we're thinking about if we have an emergency here and we need to call the squad. What are we using for an in and out bay for taking patients in and out? What that time factor is going to be, depending, it may be a longer lag than what we're used to normally because of response time. Even though they're right down the road, we're still a volunteer fire department, so there's a little lag there. So you have to learn to factor that into what we're doing. But I want everybody to think about how logistically that may work. And not here today, I see, looking around the room, and they should be. They will be at the tabletop exercise because they play a big part in this. And they have a big responsibility in what we're doing because we've just now added a whole bunch of patients to their jurisdiction where, Ken can stand up here and Ken, everything Ken has said is true and good and what have you, but when push comes to shove, it's probably not going to be Ken that's responding on that squad call necessarily.
Well, we haven't even talked about, you have an emergency now, and you may have an emergency, it may be a psychological emergency, like we said. You'd be happy to know that Ray and I already work on memorandums of understanding for the Ashland Fire Department. Ray has service contracts with the Ashland Fire Department in things like Ebola response, and this is also one of those, so you could actually have Ashland Fire. There's also, just like you, we have mutual aid agreements. Like your memorandums of understanding, if we're going to plug 30 people into their volunteer fire department, we're going to bring staff. So all those things were addressed, but we didn't talk about it. I'm glad you brought that up.
Look out here, you want to
We'll
do a
do a
tour?
walkthrough.
And then when I get back with lunches, we can break for lunch. How's that?
Sounds
Sound
good.
All right. Laura?
Thank you. I know we talked about having our patients here and all that, but our group did discuss, and I didn't hear it come up, how are our patients getting from where they are to here?
There's,
Would the facility be supplying that transportation?
just like with any MCI or some type of disaster, again, mutual aid
Would it be
agreements with school.
Ashland
If
Fire?
they need an ambulance, we would bring in ambulances. Some of these patients will come in by wheelchair. That surely was one of the things we talked about. How many
talked about
wheelchairs do we
that.
need? Well, if they're in a wheelchair, guess what they're coming in? In a wheelchair van. So there are the people that were in wheelchairs will have wheelchairs. Does that mean we don't need more? No. But do we need more the first hour?
We actually have that in our book already, the
It's our
transportation.
emergency response? Yeah.
Yeah.
Can you actually,
Yeah.
if you haven't seen it at lunch,
Sure.
take a look at that.
This is a book that, the subcommittee that we're on through the Ashland County Coalition, and it has like, every nursing home, because I'm trying now to get it added to the subcommittee. But anyway, they have, exactly how many buses they have, how many people they can transport, how many go in the wheelchair, that kind of thing, Lutheran Village, Samaritan Hospital, and then, some of the other nursing homes.
So if we had ambulatory people, we wouldn't want to use our ambulances for people who could walk and get out here in a bus, right? So it's called triaging, and we'll use a triage system to say if the first people that go are the people that go home. The next group are people that are in wheelchairs, then they'll come in a wheelchair van, and then bedridden, invalid would obviously come by squad. But those memorandums and those mutual aid agreements are already.
The answer to the question would be no, it wouldn't be probably proper. Ashland Fire would coordinate what's going on at the facility. We would put the call out like we always do anytime there's a incident that happens at one of our nursing facilities that this is going on. I can tell you transportation automatically shows up. We don't even ask for it. It shows up in the parking lot going, we're here, what can we do? So we would rely on that mutual aid network that we have, and for buses to show up, city transit would show up. They usually are very good about that. If it happened at Loudonville would be the response agency to the facility. However, we would try to provide them with whatever transportation needs we needed to get them from point A to point B. And then our plan goes into place once they start arriving. So
Let's do a walkthrough from registration, receiving, and then through registration. Just kind of see what they've done.
Okay, this is the receiving area, and the day before, this is, of course, where the trailer comes in, but there's also bays to bring the emergency vehicles in and drop the patients off. So we determined that the facilities and probably additional facilities will have larger vans that can bring the patients along with their wheelchairs. So as they come on, they are going to come on through here. So,
Why do you think this is a nice place for drop-off?
out of the weather.
Right. And there's also another one over here, so you could have both at the same time.
And in a garage.
Yep. And a third, yeah. So just so you could have all of them, right, Ray?
And then we were talking too, you're talking about the extra racks. Why couldn't they just go back on the trailer or something?
When we're done, we should just put it back on the trailer, and trailers will go out. Right?
Awesome.
Any questions
Would
on
there be enough room, you think? Is it too high? Well, it came on the trailer, right?
Any questions on the receiving? Go ahead, Bob.
Okay, when they come in, each facility should have a tag on each resident, and it has allergies, medications, their name, so this will be on each resident. And what we will do is take the name band off, put their name on, we have the registration form here, and what we were thinking, we do need a security help back here because we're going to have maybe 10 people here so that we can funnel them through, in an orderly manner. And then there'll be someone to escort them out here. We will be assigning whether male, female bed, and where we will have that plan here in front of us. So that's what we have.
Barb, do you
started.
think, you said 10 people, 10 people helping with registration?
No, I mean, if you have 10 of the residents standing here waiting to be, we're going to need somebody to help us, get them through, because it'll take a little bit of time to get them.
I just think this could be a pinch point.
Yeah.
You know what?
And I'm thinking,
We know that.
And you put chairs?
Chairs, wheelchairs.
but what about making sure that this is manned with 4, yeah.
Because it'll get busy here.
Especially if you're manual.
Right, it'll get busy.
Wow.
We'll have to get this information
I'm
down.
gonna say, right now, very few facilities have anything like this.
In every facility,
I
actually.
think there's
may
one-
have
I think
them,
there's one or two.
But
and
I
they're
think
very
the
few.
problem might be, in a perfect world, they're gonna come in with that on.
Mhm.
But there's a slight amount of turnover in long-term care. So, people that may be shipping these folks out might have just started, and they don't even know
Well,
that
hey,
this
let me
Then that'll be a
just-
problem when they get here. then.
Like Mark had talked about, at the incident itself, one of the first assignment there is a transport officer, a triage officer. These things we won't let anyone out just go wherever. Tracking is as important here as it is at the scene. People come to the scene, they have no idea that this is set up, right? So where are they going first? To the scene? The incident commander, the overall incident commander, the fire department, authority having jurisdiction of this problem has to be able to say this is where this person is. So tracking begins not here, it begins at the incident.
One thing I suggest from what we learned the last time we did this exercise. This is the same scenario we had the last time, tables in the same place. My suggestion would be to look at what steps or processes we do at this table. And if possible, divide those in half and move the first initial portion of whatever you're doing here back here somewhere. And then allow them to proceed, because this is the bottleneck. We learned that the last time we were here, so we know that exists. We need to be creative in thinking about how to eliminate that, because what's our number one objective? Safety number one, but number two, we've got people that we're bringing in here from our facilities who are now being displaced from where they're at. Their anxiety levels are pretty high. The number one thing we need to do is get them from here to a bed and start getting them calmed down and relaxed. And the easier that we can move them through here and release that sitting here wondering, what are we doing? Because they don't know what we're doing. They have no idea anything about this, so they're just sitting there in line waiting. So the easier we can alleviate some of this stress, the better off it's going to be to get patients into a bed and allow them to start acclimating to where we're at. So,
Well, then I'd say the people that do come in with tags, they have to go first, and somebody needs to be going through the line then talking to the people that don't have it and trying to get some information. And what we've told staff, and again, if it's somebody brand new, they might not know it yet, but the very least that somebody goes out with is a face sheet. If you can get it. We don't know what the disaster is. Maybe you're not going to be able to print that face sheet because everything's electronic. So, you know.
but that transportation officer back at the facility is going to be critical in communicating who the people are that are going to be showing up here before they get here. There's going to need to be an initial, these are the people that just left. They should be there in about 8 minutes, 10 minutes, whatever it's going to be. So we should already have an idea of who's coming through the door. It's not going to be just waiting on whoever comes through the door. We know that Susie Smith, Ellen Rogers, and Mary Jones are coming through the door. We know they're on their way, so we can go ahead and prep for them.
Well, don't you think, I mean, can you imagine if they've got shop class going on out here, and you got students trying to get to their lockers and trying to get fed?
This facility will do everything it can to accommodate those kind of things. If they know something's going on, they'll move these classes out of here. They'll know that we're going to use the shop, because we're going to be very disruptive to their class, as much as they're disruptive to our process. So they're not going to want to be part of that.
Okay.
So, and as far as moving patients, I guarantee you, they're going to try and keep every student, if at all possible, out of this area, because they don't want them in here.
Well, now they have logistical nightmare too.
Right.
because of us.
So now their logistics
These are not-
issues.
These are home schools.
Right.
They're home schools where they have to go back to catch up on us.
These last minute things, we're going to have to adjust, and we're all going to have to play together and figure that out. By them agreeing to allow us here, they've agreed to play by our rules somewhat, and we need to work together to make it happen.
They
So,
probably, at the very least, would be willing to just, shut that area down,
Shop.
shut this area down, and, distribute the kids throughout school somehow.
What we could do, get rid of the registration here, take them right to triage, put them in a bed, have the registration ladies at the beds.
This is why
If you
nursing.
don't want this model, and you want the people, your objective is to get them into the bed, get them calmed down as quickly as possible. So,
One of the
triage
things-
to go in there.
One of the things Steve asked everybody to do that had in their area where they were at is take notes and get it to Shar for lessons learned. And this is where you do this stuff. The lessons learned come from these, not, we don't want it to come from an actual. So if at registration, if you could, or you could make a note of that and get it to Shar.
Something else I think, that I don't know if we should do this, but
I like that.
we have a good resource right here that we may not have thought about. There's a health occupations class.
Yeah, we actually-
So we can use them, maybe some of the students could be volunteers to help.
Ray actually has a thing with the class, yeah.
Good.
The superintendent detailed access right here, but there is another garage down the way, so patients would not only come from here, but also from down there. So I don't believe anymore we would have access to what Shirley said is, a definite possibility. It depends upon what has been specifically detailed as to what we would have access to.
Well, I wanted to comment on that too, because I was here at the last one, and this was a real problem, and we have people that can't stand up for that long. So we were trying to drag chairs, just pretend, things, but still. it took forever to get through here. This did not.
I think Shirley's got a good point. I think get him into a bed,
Yeah.
and then somewhere we got on the end on the IV poles, we got the bed. Somehow we could designate that this person has been completely entered in. We've got everything we need to know, allergies, so on and so forth, and put it right on there, and then put a sticker that, okay, this person's done, move on to the next one. And health occupations might be a good resource to possibly help with that.
So we'll use one form as we get these people in, so we have one form that we can keep track of them. Because we're gonna have to have when they come in and when they're discharged too.
Well, I think maybe that's your.
You just need their name and what bed you're sending them to here.
Well, get them in the bed, and then once they're in the bed, then whoever does the intake for that patient, they come back and report to you and say, this patient's in bed number 3. Here's their name, whatever else you need to have on there.
Just right with triage, because there's room up in triage too. Just put that person.
Let's go to triage.
I think that's a really good idea. Anxiety too, to get people to their territory in their bed, that's all, not all that.
Supply area, we decided was not going to be good right in front of the doors, obviously for fire purposes. So Sally, do you want to say just a little bit about how you kind of move things around?
We just, like I said before, we're going to use these 2 carts at a time. These things are stored. We'd use those, everything else would stay behind to replenish. These carts would, there'd be somebody here at the desk to watch that, to keep the inventory and that kind of thing. We put IV poles over there.
Okay, we also have our triage section over here, Kevin.
So what we decided was one of the problems was we don't know how these patients are coming in, so we want to make sure we have their kits as soon as they come in. So if they need a gown, socks, whatever, it's going to be on the bed ready to go. The tag that they come in with, that's going to go on the by their name and their bed number where they go, and then their wristband obviously is going to be on them so we can identify it. Somebody had said something about hanging. It's going to go 1, 2, 3, 4, 5. It's going to go up and down the row. So each row, if you put a male in this bed, there's going to be a male in front of you. If you put a female over there, there's going to be a female over there. It's not going to intermix. You can't see next door.
As long as you have that number of patients, how many times in the nursing home you're like, okay, can put this person in this because this is a female room, this is a male room, they're sharing a bathroom.
Right. But
if you get enough, then
if we have 20 people that are 20 females, I mean we would make the arrangement for it.
I think the thing you have to remember are these are all movable. So if we need to make 6 beds in one little area for males because all the rest are females, you have to go to the
And that's the other thing I forgot. We do have extra. Where is it? It's in front of that bed right there. Oh, we set one of these up, but we have a bunch of them.
You want to take a look at this. This is really kind of neat.
And you can make a whole thing around the bed if you have to. Just attach them with these things, and it goes all the way around. We've got
several in that.
They're all in those boxes, and then there's several in the bed here. So you can make more privacy.
They're very easy to set it up. You set it up in a few minutes.
Yeah.
Maybe it's suggested too that the patient comes in and then it needs and then it put a red tag up. When the patient's already completely, then it put a green tag up. That way you know the process is done.
Right. And then depending on, obviously, we had set it up as a nurse and an aide for each. There's going to be 30 patients, 10, a nurse and an aide. Somebody else said 2 nurses and 4 aides. Same thing. We would just assign which way they're going. So it'd be rows this way, so they're responsible for this section. So we're not saying that nurse up there has to care for that patient back there.
The people that were in incident command, what do you think of the setup? And if you're upset that you didn't get a setup, guess what you get to do today? Tear it down, right? What do you think?
I think it's good. I think it's fun.
I was just going to mention that. Just remember, be flexible. Be flexible. It's a key part of any emergency is to be flexible. It's dynamic. It's going to change.
That's for sure. And when we looked at staffing, we looked at staff minimum because of in that first initial response, it's going to be minimal.
Right.
So as more people show up, you can reassign, you can assign other duties.
Like with command, it's expandable.
You gotta figure out what works.
I mean, it's true that, you know, we probably could use a little more privacy, but we've made some leaps from our last
Yeah,
session.
3 years ago, there were no curtains, there were no.
Plus, we're not using the room dividers at the moment, so we have 2 of those that are going unused, so it can be used for some other purpose.
Let's head back to the.
It's 30 is maximum
Steve should be here shortly.
Notification to get here, and how you were notified, you know, was it clear, was it muddy, was it timely? Okay, and we'll walk it all the way up to where we're at right now. And this is more of a process-oriented thing. So think about notification, what went well, what went wrong.
I think there was some confusion on who needed to be here today, because
Okay.
I know there's a separate coalition, and then there was us that just went through the classes. So I'm not sure, I mean, I didn't know until Thursday or Friday that I was coming today.
Okay. Clarity on attendance. There was a lot of email traffic going back and forth, and there was a meeting, and yeah, some of that probably got.
And nothing, like I wasn't in that, I mean, it was Chuck
Yeah.
saying, hey, are you coming Saturday? I said, huh?
Okay. And, you know, that's one of those things where we, the senders, thought it was clear. For you, the receivers, not necessarily, right?
Because you're folding here.
Anything else on the notification?
Well, the medical reserve corps, we all got emails, that was quite some time ago.
Yeah, so MRC was good?
Yeah.
Okay, good. That's because Ray likes to type long, funny, sarcastic email. Did y'all get the one he sent yesterday? He asked the question. Why did I ask that question? Oh, I'm so glad you asked. Look at Dave answer. He talks to himself in his emails. Okay, what else on notification? Anything? Got that? All right, so we got here. What about the overall, like the objectives? You know, we had a set of things that we wanted to accomplish today. Talk about that. Was it too much, too little? Was it? Did we say one thing, do another? Did we spend too much time on one thing?
I have to say, Steve, I was a little confused about the groups, because when we came together, we kind of had the same conclusions, so I wasn't quite sure the purpose of separating us all in that
That was an
fashion.
unintended but very positive consequence. You're right. What I thought that group was going to do was just set everything up, and we were going to walk over there, and they were going to say, we put this here because, we moved this here because. Instead, they ended up thinking through a lot of the stuff you did, which
They answered all our questions almost.
was good. So you had, and wasn't it cool how they thought about the same things, kind of the same way you did, right? But we'll put that over here on clarify roles and responsibilities of groups. Needs improved. Okay. What else? Did anybody come here, like, right now you're thinking, I thought this was going to be something totally different? Or did this kind of, did the experience sort of match what your expectations were?
I think we accomplished much more this time than we did 2 years ago. We really have.
In what way? What do you think we accomplished? I agree, but we spell out.
Well, we're making more concrete decisions in a way, getting us to think as a group and how to solve these problems.
So decisions were arrived at, group interaction. Okay, good. Problem solving.
I think it's more varied participation. We brought half our staff here because we thought, the last time when we had that, all of our management team and a bunch of volunteers came because, but like you said, it was just a couple of groups of us. It
Good
wasn't
mix.
all the nursing homes.
Well, and I think this time we focused more on goals and objectives rather than how we're going to take care of these patients. Last time we were actually out there.
That's what I mean. Oh, yeah, that happened
Acting
too.
like patients
Yeah.
and like trying to take care of them. This, we more talked about the big picture.
The operations of the
Right.
facility.
Yeah.
Well, I thought we last time tried to go through the whole thing from beginning to end. Putting people in the beds, and we even gave out M&Ms for pills and stuff last time. So this is just slower and better, I think.
So if we were going to do this all over again and spend a whole day here like this, what would we do different?
on this side, we divided up into these different groups, but we have not all need to get together and talk together because each person's function was so interrelated that we really couldn't do much when we were
We never got
separated.
to the point of breakout.
Right.
I think it'd be nice to have, like, somebody assigned to a committee, like communications part. And you, Ray, and Mark decided you're gonna be essentially on a committee to figure out how to get the word out and how to get the word back in. I think you could maybe start doing some more of that.
Committee focus is to get at some of these
Yeah,
functionalities.
this is down here in the weeds, and we're gonna need a committee for someone to work on this part of the garden.
I guess the question is, Steve, what do we do with all these, or what is being done with all the questions that come out of this? You know, we talk about these MOUs, right? Who's doing those?
Are they being done? Are they in
Yeah.
place? Do we know it? How do we know it if it was to actually need to be used? Stop.
Look at this, go with that. No, great points. Actually, that's why we gathered everything up and why Shar took all those notes. Because what we'll end up doing, probably Ray and I and Mark, and getting back together around a cup of coffee and saying, okay, we're going to take the next 2 hours and just scrub all this great stuff out of these lists and start pulling out, okay, here's a task, or here's a requirement, here's something we need a committee for, here's something that needs to be thought through. We'll push that out. And then eventually, some of those things are going to go into the plan, and we'll look at our plan and stick. If we found answers through this, we'll stick that in the plan. If we have more questions, we'll figure those out. We'll bring some of them to the tabletop. We'll bring some of them to the coalition meetings, and we'll keep working. So that's pretty much what we're going to do. Yeah, all this is necessary because otherwise, you're right. We'll walk away and go.
Well, I feel bad because the last time we did this, I talked about pharmacy then, and I didn't know, well, who's going to look into that? Well, now I'm saying I'm going to look into it.
Yeah.
Want everybody to know that, and I'm going to try and get something together.
So when we get to the pharmacy note, we're going to put a little thing. Burns got it. Burns got it. Check, done. And we have an expectation.
I know.
And you're going to fix our bed for us.
Yeah, I'm going to take the bed home and see if I can get that.
But see, that's where we've gotten, like somebody said, we finally got to Dorothy. We actually got to coming up with solutions, right? We come up with some specific things that we need to do, so. Okay, what else?
Another question, what about, looking at our strengths and top, we all lead different ways, we lead better parts, and as you saw today, I'm more one of those ones that gets down the weed. I'm thinking out here when you're just right here in the day, because we're gonna be here 4 days, sometimes I'm better at thinking out there, we're gonna need this may happen, but maybe I wouldn't be the best person for the initial where we need right in the first hour. It's just a simple thing that we learn, after 26 years of being a nurse, that's how I function. And so I wonder if we need to look at our towns and where we best fit in the different roles.
Absolutely.
Work by executive order.
You know how that works. There we go again. Who needs Congress? That's right. Okay. Anything else? Okay.
Well, I also want to say I appreciate the Medical Reserve Corps coming, because we've had a lot of interaction with them today, which I don't feel like we had the last time, and, they taught us all a lot of things today, helped us through the process, because all these terms are new to us, and we know what we need to do, we just don't know who to tell to do it. And she was able, Jane, what's her name? With us?
Yeah.
She was able to lead us a little bit, and that helped a lot.
I'm going to pray, if you don't mind, reach out to each of the individual facilities, and if I had things that come up, like resources for meds and stuff like that, what can your pharmacies do? So I don't know who, can I go through you, Ray?
I think as the facilities individually, it's given us something to look at when we go back. How do we portray who the patient is and their most critical information that they need right away? Who answers their phones on the weekends for when that call comes in? Nobody. You're not going to get anywhere when you call. You have to push a number to advance to different buildings and whatnot. So I think it's given us stuff to go back and just kind of look at individually as a building, but then a whole as a campus.
Well, and remember Tanya brought that too, memorandums of understanding. That stuff was started years ago with Mark Redfeld with the emergency response plan. So it's not just about, am I going to start the ACS today, but go back and look at your emergency response plan. We have a coalition meeting in April. We're going to start rolling out, reviewing those.
Yeah.
So go back and look at those too. not just this part of it, but what are my other parts?
Yeah.
And start that succession planning with get some people involved in those.
So I wrote that as, that you felt you got some insight on how alternate care site operations impacts facility operations and things, right? Like, oh my gosh, now that I know what it takes to do this kind of, I can go
Because
back
right
and see
now to
how-
pull a face sheet, I have to go to each individual chart to
right.
do that or print it.
Got it.
So, I mean, to look at a central location, where those are located, who's responsible for updating, that sort of thing. I mean, I think those things are huge.
Great. I'll just say thank you so much to everybody for coming. It's been great, fun day. I knew it would be fun, but I didn't know it'd be this much fun. It really was a fun, enjoyable day, and I thought we had great interaction. And yeah, thank Medical Reserve Corps. Thanks for coming out, being part of this, and obviously a huge role in getting this all put together. And we'll just look forward to February 16th.